Thank you very much, George, and participants, welcome. I know it's late, it's been difficult for all of us. I'm very excited that the people who invited me made it easy for me because they have put Professor Makrigeo, my teacher and mentor, to talk ahead of me, because it's like we read the same script, the same books, because most of what I'll say perhaps will be repeated. But just keep up. I'll be very, very brief. And in the next 15 minutes, I'll be through with a discussion on pregnancy and the kidney transplant. My name is Dr. John Ngigi. I've got no disclosures and conflicts of interest in this presentation. I'll start with a case vignette of a 25-year-old lady, now 3 years post living-related kidney transplant, whose cause of kidney disease was hypertension and chronic glomerulonephritis, and whose disease was complicated by severe uremic cardiomyopathy and pre-transplant tuberculosis. She was on MPS, prednisone and tacrolimus, and was on antihypertensive to control blood pressure. She desired to have a pregnancy because of social pressure, and she was explained to on the associated risks of pregnancy associated with post-transplant. She was hence switched off the antiproliferative agent, mycophenolate mofetil, to AZA at 150 milligrams once daily before conception. She had a stomatal pregnancy with recurrent UTIs and a difficult to control blood pressure. But she was successfully delivered at 38 weeks through a cesarean section and had a bilateral tube irrigation because after counseling, she decided she would not want to become pregnant again. We were scared after switching her off the MMF because we had a sudden rise of serum creatinine 2 weeks post. But we counseled her and we advised her to wait, as we did as well. And the kidney function stabilized at 70 micromoles per liter. After delivery, she was switched back to MPS. And today she's proud to be a mother of 2 children and she's happy. So as I make this discussion, what considerations do I need to make? First of all, I want to discuss briefly on fertility during dialysis and after kidney transplantation. I would also want to touch on the fetal-maternal complications or implications that emanate from pregnancy after transplantation. I will look again briefly on immunosuppression during pregnancy. And finally, as I exit, I'll look at the management of the pregnant patient post-transplant. As a way of introduction, we need to understand that female patients with end-stage kidney disease and on dialysis have a hormonal milieu that discourages pregnancy. Professor may have mentioned that patients or women's FSH, LH, and prolactin levels are high, and this provides a negative feedback which discourages pregnancy. But after transplantation, our endocrine function improve significantly. And of course, the medications that are used during end-stage kidney disease management may also deter pregnancy. Now, we need to look at the pregnancy outcomes for those people who manage to get pregnant. But it's important to note that the outcome of pregnancy depends really on the renal function at conception. A creatinine of less than 130 micromoles per liter will give a 96% chance of a successful pregnancy, whereas a creatinine level of less than 130 micromoles per liter reduces the chances to around 75%. In front of you is a screen that shows work of Vicky, Sin, and Stephen, a work that suggests that once patients become pregnant, their graft and patient survival are not really affected by that pregnancy. In this study, they looked at 4,000 patients, and they followed these patients for over 10 years. Within these patients, they also looked at 120 patients, 240 patients, 120 who are nariparous and 120 who had pregnancy. And the results of this is as shown here. Looking at this Kaplan-Meier survival estimates, the graft survival does not get affected by becoming pregnant. And when you look at the first graph there, patients who are nariparous and those who are pregnant progressed on within the expected graft survival curves. At the same time, the patient survival was not affected by pregnancy. Now, however, having said that, it's also important to observe that patients who are pregnant, their grafts may occasionally worsen. We need to look at the differential diagnosis for this. Preeclampsia, which has been discussed by Professor, kidney rejection still occur, recurrent disease still occur, contracted extracellular volume does occur, obstructive uropathy, physiologically from gravid uterus may sometimes become too much and cause worsening of renal function. The recurrent UTIs, we know too much, can also worsen graft function. And of course, drugs toxicity can become a problem. The fetal maternal risks associated with pregnancy post-transplant need to be known. Pregnancy does not, like I said before, cause irreversible damage to the allograft, but it depends really on the graft function. And when it's stable pre-conception, then one expects that the graft function will remain as it were. A study which was done in UK transplant registry showed that at 2 years post-pregnancy, graft survival was as good as over 95%. However, any pre-existing kidney disease is an independent risk factor to preeclampsia, with the risk directly related to the renal function, which Professor alluded to earlier. And a proteinuria of more than 0.5 grams per day increases the risk of irreversible graft loss. What about hypertension? Independent hypertension is a cardiovascular risk factor. And every time we mention hypertension, regardless, we know that there's a problem there. Now, of course, Professor did talk about gestational hypertension, which commonly occurs for those patients who are not hypertensive before transplant, when they get pregnant. In normal gestation, blood pressure is lowest during the first trimester and returns to pre-pregnancy scenarios towards term. This can be challenging, as was said earlier, because many patients will still be on medication and one needs to be very careful when making a diagnosis of hypertension. But the point is, we must target to achieve normal tension. Very low blood pressure is not good for pregnancy, and of course, very high blood pressure is not good either. This preeclampsia is a disaster, and I will not spend too much time discussing preeclampsia, but Professor has really spent a bit of time discussing the complex pathophysiology of preeclampsia, the angiogenic and the anti-angiogenic factors, the SFRIT and the PGLT, and all those things he said. But a high index of suspicion is important and is required, as patients will often have hypertension, proteinuria, and hyperuricemia. We need to classify the preeclampsia based on the hypertension and proteinuria, and the worse it is, the bad or the worse for the pregnancy. Look out for HELP syndrome, and of course, for academics, consider the other differentials: fatty liver of pregnancy, HUSTTP, malignant hypertension, scleroderma renal crisis where applicable, and others. Now, you may not be able to stop preeclampsia if it was coming, because there are some, like I said, complex scenarios that present with preeclampsia or cause preeclampsia. Now, when patients do present to us and they're pregnant post-transplant, it would be nice to ameliorate or to slow down that risk of getting preeclamptic. Aspirin, 75 milligrams once daily from start to end of pregnancy. Blood pressure should be less than 140/90. Nephrotic ridge proteinuria requires daily RO molecular weight heparin. These are some of the strategies that might be useful to prevent preeclampsia. What about the medication? This one has been said before, and I'll not talk about it, except maybe to mention that diuretics, when used, should be used cautiously because of the risk of contracting the extracellular volume and causing an AKI. The good drugs that we use every other time, the beta blockers, can be used, but the non-selective beta blockers, the atenolols, the propranolols, may not be used because they can cause uterine contraction. And of course, ACE inhibitors and ARBs are contraindicated, particularly in the second and the third trimester, because of the risk of causing renal agenesis and other renal malformations. Dr. Jogu, in his study recently, did show that post-transplant pregnancy is a risk factor for UTIs. And he did identify Klebsiella, Proteus, and E. coli as major bugs. Now, what the message would be then is that we should routinely monthly screen our patients. And when they have even asymptomatic bacteria, they should be treated for that for 2 weeks. And consideration should be made for prophylactic antibiotics to be used until term. Do patients get kidney rejection when they are pregnant, post-transplant? Of course they do. And the risk factors for kidney rejection in these scenarios are as normal people. In itself, pregnancy does not increase the risk of getting a graft rejection. But we need to understand several things that happen in the physiology of a pregnant woman. The volume of distribution, the fluid shifts that occur, the adipose tissue and the red cells, all of them have a direct impact on the pharmacokinetic and pharmacodynamics of the drugs that we use, and this could put a risk to rejection. And of course, like Professor said earlier, the interpretation of serum creatinine need to be cautiously used due to the hyperfiltration that occurs in pregnancy, such that a subtle rise in serum creatinine would mean a lot. A renal biopsy is not contraindicated, and Professor in his 35 years has done one renal biopsy. In this age of improved imaging, then we can be able to do renal biopsies if the risks outweigh, the benefits outweigh the risk. And steroids will be used for treatment and other drugs that were alluded earlier. I have managed to convince you that pregnancy post-kidney transplant is a very risky affair, just like my teacher said earlier. But if I haven't, I have displayed to you a 2010 meta-analysis study that covered over 1,300 studies. And the studies that qualified to be put into analysis were 50 studies covering over 4,706 pregnancies and over 3,000 kidney transplant patients. What is interesting is the outcomes of this study. The complications of the pregnancies included preeclampsia at 27%, gestational diabetes at 8%, a very high cesarean section rate of around 60%. When we continue with the study, the results of the study, pregnancy outcomes were more favorable in studies with low maternal ages, like young people, people who are normotension at conception and throughout the pregnancy, and those patients who got pregnant at longer duration of time between kidney transplantation and pregnancy. 30 to 50% of the pregnancies experienced intrauterine growth restriction or retardation and gave an averagely low birth weight babies. But rejection was just like in normal population. Now, should patients get rejection, they must be treated. And again, Professor talked about it earlier, and birth defects appears to be similar to general population, except for those who use mycophenolate, who will observe a 23% incidence of cleft palate and hypoplastic nails. Mycophenolate and sirolimus are contraindicated. Steroids have no teratogenic effect at therapeutic doses, but very high extra doses may increase risk of abortion, intrauterine growth retardation, diabetes, and hypertension. CNIs, although we use them because of lack of other things, may cause preterm birth, hyperkalemia, gestational diabetes, especially for tacrolimus. And of course, azathioprine may cause transient cytopenias that disappear after a month. So what do we do to prevent pregnancy? Because not everyone wants to become pregnant. We must advise on use of contraception as early as possible. We must avoid pregnancy during the peri-transplant duration, the first 6 months, particularly due to the teratogenic effect of the drugs we use, which are often on very high doses. If we must use pills, then let's settle for the low-dose estrogen progesterone pills. But remember the risk of thromboembolism, and we must also monitor the CNI levels because of drug-drug interactions that exist. By and large, barrier methods are best, but avoid the intrauterine devices because of risks of infection. So the American Society of Transplantation has come up with guidelines on timing of pregnancy post-kidney transplant. The graft function should be optimal, and optimal is defined as less than 132 millimoles per liter, micromoles per liter. The protein excretion, if it's there, must be less than 500 milligrams per 24 hours. There should be no concurrent phytotoxic infections such as CMV, which means you must screen your patients as well. The patient should not be on any teratogenic or phytotoxic medications. And patients should have a stable regimen of immunosuppression, which means that the patients should have a stable graft function. And in conclusion, ladies and gentlemen, kidney transplant recipients must undergo major physiological changes in pregnancy. This has a bearing on the pharmacokinetics and pharmacodynamics of drugs used, putting us at risk perhaps of rejection. Contraception and preconception counseling is crucial. Multidisciplinary care between obstetricians and nephrologists is crucial. And really, fetal outcome depends on a good graft function. And it's important to know, and we tell our patients, that pregnancy does not put the graft at risk of rejection in itself, but rather the concurrent situations that happen or any long-term graft function. Thank you very much for listening to me.
If you don't mind, I'll just use the advantage that I have and ask a few of my questions. And Dr. Ngigi, you emphasized, and I think Prof also on your presentation, in terms of the pathogenesis of the renal dysfunction in these patients. And do you think it has to do, because you'd expect that these patients are hyperfiltering, and perhaps you'd think that the creatinine, as mentioned, would be falsely low. But many times you do see an elevation in the creatinine and a reduction in the estimated GFR. And do you think this pathogenesis is related to elevated intraglomerular pressures, in the inability to produce more erythropoietin and maybe increased anemia? Maybe you could comment on the pathogenesis of the renal dysfunction, and maybe I would start with Prof on that.
You seem to be asking a question about allograft function rather than chronic kidney disease per se.
Mainly asking both in renal, in the allograft, and both in patients who have CKD, say CKD3 and beyond that. What is the pathogenesis of the renal dysfunction that we see related to increased intraglomerular pressures? Is it related to, because I would expect, as we normally see in pregnant patients, you normally see the estimated GFR actually go up and they start hyperfiltering. And I would have expected to have seen the same in these pregnant patients, but instead we see a deterioration in GFR. What do you think, Prof? In the CKD patients and in the allograft patients, then Dr. Ngigi?
Let me make a very brief statement there.
Yes, sir.
From common sense,
yes,
it would appear that what you're saying is the truth. Because in both groups of patients, the allograft patients, and let us not forget that the allograft kidney is a state of chronic kidney disease.
Absolutely,
so we are talking of chronic kidney disease in all these patients. So you are starting from a reduced mass of nephrons, and you have that state of pregnancy with the physiological changes that Dr. Ngigi mentioned and I also alluded to. So it would be correct to say theoretically that these patients are hyperfiltering, and that could contribute to the worsening of their kidney function. And I would like to leave it at that. I think that makes sense to me.
Dr. Ngigi, any comment?
I think I concur with the professor that the hyperfiltration in itself may worsen the sclerosis and the loss of growths that happens.
Absolutely.
The only thing that we perhaps may want to look at is that despite this, patients who do recover, who do get pregnant and they are, they have a new kidney, may not continue worsening their kidney function even after recovering, which means that there may also be other elements that we probably don't understand more in the pathophysiology of this disease. Because patients who, if they get an acute kidney injury after pregnancy and they recover, their kidney function recovers as it were. It doesn't worsen, it doesn't progressively worsen.
That's interesting. May I also ask whether both, in these cases, perhaps some of the damage that we see is because of the absolute having to withdraw our medication in the form of ACE inhibition and in the form of ARBs, and sometimes even diuretics, if the obs-gynes would have their way. Is it Dr. Ngigi, you said it's an absolute contraindication. I think Prof also mentioned the same. There's been some data talking about, people using ACE inhibition and ARBs, and just from the one patient that I had who happened to get pregnant on dialysis, and we discovered it very late, and she had been on ACE inhibitors and ARBs throughout, very high doses. I don't know, would you comment on it in terms of your personal experience? Would you absolutely withdraw ACE inhibition and ARBs? I think you have said that you would. What would you comment in terms of your personal experience?
Let Professor first talk about his personal experience, because it's very lengthy, of 35, 40 years. Then I talk about my short one. Professor.
Yeah, okay, it is not the duration so much, but I personally have not seen the teratogenic effects. But let us put it this way. Even when we were giving our speeches, we said that these drugs, call it MMF or call it ACE inhibitors, do have these effects, but these effects occur in a certain percentage. It is not even over 50%. You're talking of 30%, 25%, 46%. So the risk is there, but it is not an all kind of thing. So if you do have pregnancy in a patient who is taking ACE inhibitors, do not assume that they are perfectly safe. And as I mentioned at the beginning of my speech, walking on the streets, you might be thinking that you see so many of these patients, but that is not true. Given the kind of numbers I'm telling you, researchers have been going through over the years. So you are seeing few. If you see one patient or 5 patients and they don't develop, they get pregnant and you don't observe any teratogenicity, that do not mean that these drugs are safe. But you don't go into it just assuming that everything will be okay. You mentioned, I'll go back to it briefly. You mentioned something about the progression of chronic kidney disease in allografts and native kidneys. Glomerular diseases, as I mentioned, we use several drugs, and in all transplant patients, we are using, most of them are on CNIs. So if they become pregnant or not, all these other factors, drugs and any other things which might influence kidney function, play a role. So it is not just the pregnancy in the patients who become pregnant that influence their decline in renal function. You must remember that they are on CNIs, and this will contribute to this. Pregnancy or no pregnancy, delayed graft dysfunction, both would contribute, but Ngigi seems to know more about these things.
I think there's a lot of wisdom in what you have said, but perhaps I would say if these things have been observed in animal models and rats, then we shouldn't want to experiment on them, because even 0.1% is too much, or let's say 1 or 3% is too much if it happens to one patient. But simply put, second and third trimester is not a nice time to put in those ARBs, because they can cause, or they have been observed to cause, renal agenesis and other renal malformations. Perhaps, Dr. Soki, you may have observed this, you may have noted that your patient was on ARB, ACE inhibitor during the first trimester. People do not seem to think that first trimester is such a disastrous time, perhaps based on how the renals develop in utero.
Yeah.
Thank you. First of all, very, very happy that I was called in to have this discussion, because I have a vision and a future where we are going to have nephrologists who are going to concentrate and dedicate their time to doing obstetric nephrology. When that time comes, I would imagine and believe that our pregnant mothers who get post-transplant pregnancy will be taken care of much more than we are doing. Professor, to you. Thank you, Dr. Soki.
Yeah, just as a closing remark, generally, if I'm called to review an obstetric patient in Quant with kidney disease, be it allograft or native kidney, it is usually good to be part of the team right from the time you are called up to the end of the pregnancy. And I think I've done that over the 35 years that Ngigi is talking about. Anytime I try my best so that both the mother and the child come of it. And many of you might not know, I visit our neonatal unit severally when I'm reviewing this patient, just to check on their preparedness to deal with the outcome of such pregnancies. Thank you.